Hey everyone, we've got another brilliant case study for you today. This patient has strange neuro symptoms in their upper limb. Can you work out what's going on? We're going to take you through the assessment and all the clinical reasoning to explain so it helps you in your clinical practice. If you're ready, let's dive in. Hey everyone, Khalid here. Welcome back to Clinical Physio. Great to have you with us for another case study. Let's go through the subjective history for our patient. So, we have a 46-year-old gentleman presenting in our clinic with right-sided pins and needles and numbness in the medial side of his right forearm and into the fourth and fifth fingers of his right hand. He's noticed that this has been gradually getting worse over the course of the last 6 months. He hasn't found a clear reason in his mind as to why it started. He hasn't had any injury, no trauma. His work's been manageable. He's just found that it's been gradually coming on. And strangely, he doesn't have any neck pain and any elbow pain, but he does find that he has some pain around the anterior right shoulder that has been there for the last 6 months in line with his right-sided pins and needles and numbness and pain in the forearm and the fingers. So, the other things that you find out when you quiz him a little bit further about his past medical history is that he's a heavy smoker. He normally smokes a pack of 20 cigarettes every day for 20 years. And so therefore it shows you that he has been smoking for a long period of time. And in line with this, he seems to have had a worsening cough over the last 3 weeks. And so you wonder whether or not that might have something to do with his current symptoms. So next we go through his objective examination. And strangely, it's largely unremarkable. He walks in with no issues with his gait. He's got a normal gait pattern, no loss of balance or anything like that. You look at his neck, which seems in pretty good shape. He has no pain on palpation of the cervical spine. He has no pain on active range of movement of the neck. He's got full active range of movement there, which isn't reproducing any pain. You also do a Sperling's test with him. So this is where we extend the neck, side flex towards the right hand side because that's his symptomatic side, and then compress down, axial compression through the cervical spine in this position. This doesn't irritate his symptoms either. You look at his spinal neuro, so myotomes, dermatomes, upper limb reflexes, no issues at all there. And then we look at the elbow. We think about active range of movement of the elbow, which is full, doesn't cause any pain at all. And when you do Tinel's test in the cubital tunnel, that is also negative, doesn't show any signs of any issues whatsoever. So, from this history alone, I'd love you to pause the video and have a think to yourself about what you might think could be going on with his symptoms. Maybe have a think to yourself about why we've been looking at the cervical spine, why we've been looking at the elbow. Could there be any other reasons as to why his symptoms are getting worse? Pause the video, write down your thoughts, and join us in a second. So everyone, with that in mind, let's go through the diagnosis. And unfortunately, I'm afraid there's a little bit of a sad reason for this patient's symptoms because he was suspected of having a Pancoast tumor. So let's talk all through that. So a Pancoast tumor is a rare form of lung cancer. It is an apical lung cancer. It happens in the upper lobe of the lung around about the first rib, and according to Gundapalli et al. From 2022, it accounts for 3 to 5% of all lung cancer diagnoses. So if we look back at this X-ray, you can hopefully just about see where the black circle is there, that there's a quite marked white outline that seems to be present in the patient's right lung on the upper lobe, but not on the left side. And unfortunately, that was the sign that led to the diagnosis of a Pancoast tumor. The fact that he had been experiencing his symptoms with the worsening cough prompted a chest X-ray, which found this outline. So some of the key things around Pancoast tumors. As we said, they account for 3 to 5% of all lung cancers, according to Gundapalli et al. And unlike most lung cancers, sometimes a Pancoast tumor strangely doesn't cause worsening cough or chest pain. One of the key symptoms from a Pancoast tumor is symptoms in the arm, particularly around the fourth and fifth fingers. Why is this? So when the tumor is present around the apex of the lung, as you can see from where I'm pointing, it's around the shoulder area. And sometimes the presence of that tumor in that shoulder area can put pressure on the brachial plexus. One of the most inferior nerves of the brachial plexus is the ulnar nerve, and therefore it can be the one that's closest to that Pancoast tumor in the apex of the lung. And that's why sometimes patients can experience pins and needles and numbness in the fourth and fifth fingers and in the medial forearm, because that's the same distribution as the ulnar nerve. And so a really interesting condition. As we said, sometimes this doesn't cause coughing symptoms. In our patient, it actually did. But one of the hallmark signs, as we said once again, is the pins and needles and numbness and the symptoms that he's experiencing in the fourth and fifth digits and the medial forearm. So finally, let's go through some of the key points and clinical reasoning within our assessment that take us through that diagnosis and down that line of a Pancoast tumor. So when we think about patients who have pins and needles and numbness in the fourth and fifth fingers and in the medial forearm, a Pancoast tumor is one potential cause. However, as we said, it's a much more rare one. What are some of the other natural conditions that can cause those symptoms? The two main ones we will think of is a cervical spine radiculopathy, particularly around C7, C8, T1, as those are the nerve roots that stem from and create the ulnar nerve. And the other is cubital tunnel syndrome. The ulnar nerve runs through the cubital tunnel on the medial side of the elbow, and it can get compressed in there, which can lead to those symptoms in the medial forearm and the fourth and fifth digits. You might also think of Guyon's canal in the medial hand. However, that shouldn't often cause symptoms in the forearm. It might cause symptoms more distally into the fourth and fifth fingers, but not the forearm. So we're thinking about cervical spine and cubital tunnel syndrome as the most common two. However, as you can see in the take-home message in the bottom corner, don't make the symptoms fit when they don't. This individual had no indications that his cervical spine was the cause for his symptoms. He had no neck pain, he had no pain on palpation, no pain on range of movement testing, a negative Sperling's test, and a negative neurological examination in terms of myotomes, dermatomes, and reflexes. We had no evidence at all to suggest that his cervical spine was the cause of the symptoms. We also couldn't make the symptoms fit in terms of cubital tunnel syndrome. He had full active range of movement at the elbow, no aggravating symptoms around the elbow, and Tinel's test around the cubital tunnel was also negative. So therefore, when the symptoms didn't fit the normal cervical spine pattern or the normal cubital tunnel pattern, it led us to think a little bit further outside the box. And that's where, unfortunately, the suspicion of the Pancoast tumor came on because of his large smoking history. As you can imagine, lung cancer, the risk factor increases significantly when you have a smoker, particularly one who's been smoking for 20 years, and the recent cough. I know we said in the previous slide that sometimes Pancoast tumors don't present with a worsening cough. In this patient, we did, and therefore it was just one of those additional things that made us thought, these symptoms are not fitting in with the normal patterns of either cervical spine or a cubital tunnel syndrome. So when the symptoms don't fit, don't make them fit and look further down the line. And that's where we decided to explore a little bit outside the box, referred him back to his GP for the chest x-ray, and unfortunately, that's what picked up the Pancoast tumor. However, the key thought process, therefore, really think about, do your patient's symptoms fit? If they don't fit, that's the time when we should be getting help from elsewhere, referring on to other practitioners, getting senior clinicians involved so that we can get to the right diagnosis for our patient. So everyone, I really hope you've enjoyed today's case study and it's helped you with your clinical reasoning. If it has, please support us by smashing that like button and subscribe to our channel for all our best updates. Remember, if you want more resources, we've got a fantastic Instagram account at Clinical Physio with loads of brilliant resources for physiotherapists. And if you like learning from case studies, please do check out membership where we have the Case Study Club. Link in the description below for membership, member.clinicalphysio.com. The Case Study Club is a brilliant resources that we've got over 100 episodes in, where we have clinicians come on to take us through their patient and explain all the key clinical reasoning behind why they did what they did in terms of their patient. So if you like case studies, check out membership, check out the Case Study Club. Otherwise, my name's Khalid. Thank you so much for watching. See you soon here on Clinical Physio.